Hi friends, this update to the DVD is following the release on August 2nd, 2013 of the CMS Rule 1599F, which talks about inpatient hospital admission and medical review criteria, as well as the inpatient prospective payment system final rule that has been in the comment arena for quite a few months now. What is important to inpatient acute hospitals is the topic of the 2 midnight provision as well as the Part B billing. This rule instructs physicians on when an inpatient hospital admission should be ordered and certified and clarifies for the practitioner and facility when inpatient hospital admissions are generally appropriate for Medicare Part A payment. The new rules were intended to address concerns that Medicare beneficiaries having long stays in the hospital as outpatients um, and to improve the program integrity. So under this rule, if a physician expects a beneficiary's surgical procedure or diagnostic test or other treatment to require a stay in the hospital lasting at least 2 midnights and admits the beneficiary to the hospital based on that expectation, it is generally appropriate that the hospital receive Medicare Part A payment. This final rule also emphasizes the need for a formal order of inpatient admission to begin the inpatient status, but permits the physician to consider all the time a patient has already spent in the hospital as an outpatient receiving observation services or receiving care in the emergency department, operating room, or other treatment areas in guiding their 2 midnight expectations. Now, CMS finalized the proposal to continue applying the timely filing restrictions to the billing of all Part B inpatient services, under which claims for Part B services must be filed within 1 year from the date of service. Now, the CMS ruling 1455 R had an effective date of October 1st, 2013, and it also allows hospital to follow the Part B billing timeframes, provided that Part A claim denial was one to which ruling originally applied, or the Part A inpatient claim has a date of admission before October 1st, 2013, and is denied after September 30th, 2013, on the grounds that although hospital outpatient services would have been reasonable and necessary, the inpatient admission was not. Now, the rule also discusses appeals, beneficiary liabilities, and other impacts of its final policies. Now, this rule that CMS came out with is about 2,225 pages. What is important to acute hospitals is the Section 11, Chapter 13, Part C, from pages 1781 to 1851, and these are payment policies related to payment to patient status, and it gives instructions about physician orders and certifications, the inpatient hospital admission and medical review criteria. So where the rule talks about the 412.3 Part A of the requirement of an order by the physician, and they usually recommend at the time or before the time of admission. The rule states that orders that are done after surgical procedures or interventional procedures should be rare, and adequate and extensive documentation should be written on why this order was not done previously. What is important is the 2 midnight rule does not change the requirement of need, or as we always talk, medical necessity of this patient for medical treatment. And again, the requirement of need by a physician for this treatment or inpatient diagnostic study is still what it was under 424.13a. CMS also talks of the requirement of information to justify the admission and continued stay, And again, this is where this DVD comes into play on what documentation, what criteria, what objectivity do RAC auditors, MAC auditors, and CERT physician reviewers look at, um, even though the question about inpatient and observation seems to be at least settled at this time. The core question is the need for, or as we describe, medical necessity of this patient. CMS refers us to the Medicare Claims Processing Manual, as well as the Medicare General Information Eligibility and Entitlement Manual regarding physician certification of orders. They also talk about a verbal order policy in which they clearly state that the use of verbal orders is for the convenience of the physician and the hospital. However, those need to be signed appropriately as per Medicare guidelines as soon as possible. Signature requirements on the are pretty extensive on what Medicare expects us to do. Um, the order should have um, a full evidence of a medical history, physical admitting diagnosis, results of all consultative evaluations, documentation of complications, hospital-acquired infections, unfavorable reactions to drug and anesthesia, properly executed informed consent forms, practitioner's orders, nursing notes, reports of treatment, discharge summaries, and they do require a full physician order that has been signed, dated, timed, and in case of verbal order, properly authenticated by the ordering practitioner. CMS has been very clear about denials of billing if these basic requirements are not met.